Hey, good morning and welcome to Open Mics with Dr. Stites. It's Wednesday, October the 12th. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. How many of us are willing to put our lives in the hands of a stranger? That's exactly what happened when these two men teamed up long before they knew each other. One desperately needed a life-saving bone marrow transplant and the other answered the call. Today, you'll see their emotional meeting for the first time after the procedure. We'll take a close look at what's done and what's involved in being a donor and a recipient. Joining us here in the Dolph Simons Jr. Family Broadcast Studio are Dr. Sunil Abhyankar. I've known him. I know his kids. I know his wife. Great family. Director of the Midwest Stem Cell Therapy Center, and Tricia Rasmussen. And I said it right.
You did.
Are you married into it, you said?
That's right.
Okay, well, you have to still claim it. All right. She is the lead transplant coordinator for blood and marrow transplant. Welcome to you both. We're delighted to have you both on the program. Questions from our viewers are an important part of this program, and we want to hear from you. Get yours sent in to us now on YouTube, Facebook, Twitter, and the Medical News Network. You'll find those links right here on your screen. Jessica Lovell will join us a little later with those questions. Before we get to that topic, though, we have an exciting major development. It's about a potential new treatment for Alzheimer's disease, and we wanted to share the positive results with you as quickly as possible. Joining us virtually is Dr. Jeff Burns, a neurologist and co-director of the University of Kansas Alzheimer's Disease Center. Dr. Burns, this new drug is called, say it for me, Jeff. The drug is called?
Lecanemab.
Lecanemab. I was going to say Lecanemab. Okay. And you're testing it here as some clinical trials. You're actually part of this, the folks who are actually doing the drug testing. Tell us why it's so encouraging. What are your thoughts?
Yeah, so just about 10 days ago, an announcement was made looking at 1,800 people who were tested with this drug with Alzheimer's disease, and it's very encouraging. What was released was called the top line data, which is just the first look at the key outcome measures, and the results were positive, meaning there appear to be benefits in basically every measure of these primary and secondary outcomes. And that's the first time I've seen that kind of an announcement or that kind of result in an Alzheimer's study. So we're encouraged now. This is a press release. We haven't seen later next month, we'll see much fuller sort of data set and release of the data. But so we're cautious, but we're encouraged.
You know, I'll just say, like, what the vaccination things and stuff, that press release, they tend to be sticking pretty true to the data. So Lecanemab, that would be an amazing development. How is this different from Aduhelm? I don't even know how to say that one, Aduhelm, whatever. The one that does work, and had a big fight with the FDA and everybody in the insurance companies. Talk to us about the difference.
So Aduhelm, it's very similar to the drug Aduhelm, which was approved by the FDA in June of 2021. And lots of controversy around that because the clinical data wasn't definitive in terms of benefits for the patients. And the FDA approved it in an accelerated way. And so we've been arguing over how big are the benefits and the drug works in a very similar way. Lecanemab works very similar to Aduhelm. It goes after the amyloid in the brain of people with Alzheimer's disease. There's a buildup of amyloid in the brain. And so it works in a very similar way. But what's different here is much stronger clinical data, demonstrating there may be some very positive benefits to this drug in terms of slowing the disease.
Wow, that would be so impressive. But why would it be different between Aduhelm and Lecanemab? What would make it different?
Yeah, you could probably think of them as very, very similar. There are some key differences to what part of the amyloid is targeted that may turn out to be important. But actually, one way to interpret it is that the studies were done a little differently for Aduhelm, and they were actually stopped early. And so there may not be enough data to know if Aduhelm really helps versus here with Lecanemab. The trials were done a little bit later. They were done, a little more fully, and the clinical data suggests, appears pretty strongly suggests there's some benefits. Whereas in Aduhelm, we maybe just don't have that data yet that the clinical benefits are there.
So Jeff, who's likely to benefit from Lecanemab? I mean, this is a big deal.
Yeah, so the way it's been tested and the way it makes the most sense is people with really early Alzheimer's disease or mild cognitive impairment, which is kind of a pre-Alzheimer's state. So people with mild cognitive impairment and early Alzheimer's who have, who we've proven have amyloid in their brain, and there's ways to do that through imaging or spinal fluid testing. So it's likely that we'll be, we're again, I'm thinking ahead, but we expect that this may be available for people in those earliest stages of Alzheimer's disease.
How much does it appear to slow, Jeff? I mean, Dr. Burns, is that big slow, a little slow?
Well, yeah, we're going to be debating that. That's probably the arguments you're going to hear in our field are going to be about how big of an impact does this have, and that 30% slowing is what was reported in the press release. When we get the fuller data set, we'll understand that a little bit better. But 30% could be substantial, and it could also be not so substantial. It kind of depends on where somebody is in the stages of Alzheimer's. Early on, a 30% slowing in the MCI, the very earliest stages, could be a really big deal. But if it's middle stage, late stage, it may not be so important or so recognizable. So so that's going to be interesting to see. That's why we're all waiting to see this full data set.
You bet. You want to compare it to where people are in stages and watch progression of it. So when you were trialing the drug, I mean, it was one of the study sites. Could you tell a difference in patients who got it or didn't get it?
Well, I try not to do that, because we don't actually, when we're testing things,
you don't know.
We don't know if they're on placebo, if they're on real drug. And Alzheimer's there's a lot of variability in Alzheimer's. It can move very slowly and it can move very fast. And so,
it's really an unfair question. So we did the CF study drug. It was easy to tell because the people who were getting the treatment drug, they all felt so much better and their lung function got better. Like, oh yeah, you must not have gotten the placebo, and we were right because it was such a clear difference. But when it's a little more subtle, it's harder to tell, I think. But still, this is really big news, and it feels like it's big news for two reasons. First of all, improvement, but second of all, proof of concept.
Yeah. So this. We've been debating what's called the amyloid hypothesis for decades. And, does amyloid cause the disease? Is it the byproduct? Is it the smoke or the fire? And this doesn't really prove, the amyloid hypothesis. But, if this holds up and if other, drugs that target amyloid hold up, we've spent decades testing things that didn't hold up on the amyloid hypothesis. Now we have some of the first studies showing that people may benefit. And so it does potentially prove this concept that amyloid is a viable target that we should be going after. And I tell you, 2 years ago, I didn't believe it was at all. And now I'm we'll see, but I may be a believer here soon.
Well, you're one of the world's leading researchers. How close do you think Lecanemab, or Lecanemab, however you call it, this new drug, how close is it to FDA approval?
Yeah, that we're again speculating, but they should have an initial ruling on it by January in that accelerated pathway.
Yeah.
But we're expecting, within a few months of that, if not earlier, to see potentially full approval. And then Medicare has to come around. Now, Medicare decided with Aduhelm not to pay for it unless it was being delivered in research, which is a big decision. And they actually apply that to all of these drugs that target amyloid in this way as an antibody. And so they're going to have to do a review, I think, and decide whether or not they're going to pay for this. So there's a couple steps that need to happen, and we have really no insight into how FDA and Medicare will rule at this point. But those need to happen, and then we'll see. Will we be prescribing this to lots of folks or just a few? By next summer, I expect.
We'll know a lot more. I think it's going to be a lot harder for Medicare to say no to a 30% slowing when they've said no to 30% improvement in cancer. We'll talk about that in a minute with Dr. Abhyankar, but that's real, right? That's real, and I think they'll be under a lot of public pressure around that. Well, Dr. Burns, thank you for joining us. We're going to have you in for an update, especially as more of the results come out in full. You got to get on open mic so we can sit and have a really good discussion. Jess, everybody, hope you're hearing that. We're going to bring him on. I want to have a full discussion of this whole field. So awesome stuff.
Thank you.
All right. Thanks, Jeff. We'll see you soon, Dr. Burns. All right. This is a story of a Kansas City man who was desperate. He needed help to survive, and he found it from a stranger living in England. We were there when the two finally met, and Jill Chadwick brings us that emotional moment. Jill.
This hug is 8 years in the making. It's the first time this very special family is coming together.
In 2014, outside I was diagnosed with leukemia, and my life was in danger, and desperately need a stem cell transplant.
David Zhang was living in the Kansas City area and needed a stem cell donor. Reese Mabbitt, an undergraduate medical research student at the time, was living in England. He was David's rare 100% perfect match.
When I found out, I was very, very surprised, obviously.
David was grateful and relieved, as donors are hard to find, let alone being so perfectly matched. But Mabbitt was just 19 and small in stature.
They were worried that if I didn't generate enough stem cells, they would have to do the more invasive procedure, and that usually puts people off donating in the first place.
Reese's blood marrow donation was a success, and so was David's transplant. But the rules require donors and recipients wait 2 years before meeting. Hard as they tried, school, work, distance, and then COVID delayed this in-person moment that began 8 years ago with handwritten notes.
So it kind of went from, I think we exchanged a card maybe, and then it went to emails, and then we got each other's numbers and we were sending pictures.
But nothing beats in person.
Really kind of happy, excited, I feel I did something from my heart.
While in the States, David wanted to share the hospital where he received Reese's life-saving stem cells. Reese said it reminded him of home.
I worked in different laboratories and hospitals, mainly focusing on blood sciences. So I've gone from blood sciences to blood cancer.
That line divided, that means there is this is in Kansas.
The student turned scientist who gave the gift of life is humbled by David, who sees Reese as much more than a donor.
So see him, that's my savior, so he's my hero.
No one's ever called me that before. Don't really know how to take it in. Obviously, I understand where he's coming from, but just because I'm a very humble person, it's nice.
David and Reese are planning a good long visit that includes a trip out west.
Dr. Abhyankar, tell us about David and his cancer, how he's doing today. That story, I get teary-eyed. I get teary-eyed reading it, I get teary-eyed listening to it, I'm a sap, but that's an amazing
That is an amazing story
yeah.
for sure, and we are fortunate many times to share these stories like that for patients who are doing well. So David had blood cancer, acute myeloid leukemia, and
that's not a good kind of cancer.
That is
you
not
don't want that. That's
you
bad.
don't want that.
Yeah.
You don't want that. And he was diagnosed in 2012 when he had the leukemia, when his blood count started to drop. And further workup, like a bone marrow test, etc., revealed that he had acute myeloid leukemia, not the good kind. There are some acute myeloid that are kind of good, that may not need transplant, but he didn't have that. So it led us then to give him chemotherapy. He was in the hospital for about a month, receiving that chemotherapy, at the end of which we then did a bone marrow test and showed that he was in remission. Remission doesn't mean the cancer is gone, it just means that we can't detect it. And that is why we needed to proceed with replacing his whole bone marrow with a donor's bone marrow, which is bone marrow transplant or a stem cell transplant. And David was lucky because, as you can see from the video, he is Oriental ancestry. And finding donors, he didn't have any matches in his family. We typed his siblings, they were in China, and we typed them and they were half match with him.
And that's not a great match.
That is not a great match, and especially back in 2012, the half match transplants were not as prevalent, and the science was not as advanced as it is now. And so we, even today, if you have a match donor, then we would prefer going with a match donor most of the situations. And so that's where we reached out to the National Marrow Donor Program and their registry. which we routinely do, and Trisha, who is the lead transplant coordinator in the BMT program, they do this all the time, every day. And the latest statistics, there are more than 30 million donors who are going to volunteer donate their stem cells. And amazingly, we found a match for David. And as you saw, he was a young man in England. And I happened, when David brought him here, I happened to talk to him. I asked him, how did you decide to go on the donor registry? And he said, when he was in college, he had somebody a friend I think, who had leukemia. And that kind of inspired him to go on the registry and help other people. Totally altruistic and amazing, gesture. And but he signed up, and he said within a couple of years, actually, of being on the registry, he got called that he matched. And the very interesting thing in the DNA-wise is how genetics works. I mean, here we have a Asian or Oriental.
You got a guy from Scottish and somebody from an Asian.
That's right.
That's an unusual, like twin sons of different mothers. How did that happen?
Exactly. Isn't that amazing?
I read that. I was like, holy cow! This is such an unusual thing.
It is. Yeah. It is a very unusual thing. But David was lucky. He had this match, and lucky to have met such a fine young man, Reese. So he went to the transplant, and for the transplant, again, David had to go through a lot of chemotherapy, pretty intense chemotherapy. He got quite ill, and then the stem cells actually were couriered from England, London, to here in Kansas City on the day that we needed them. And he received his transplant, which is a transfusion of these stem cells to the recipient.
Wow. So bone marrow transplant is also called stem cell transplant. It's gold standard for curing blood. How does that work? I mean, because again, I'm still a little astonished on the whole Scottish Asian thing.
Yes.
That is cool. Once again, showing that the color of your skin doesn't determine who you are, and it certainly doesn't determine your genetics. Let's just be clear.
Well put. Yeah. Exactly. Yeah. So So how does a bone marrow transplant actually work? In order to, you can consider a bone marrow transplant like an organ transplant, kidney transplant, heart transplant. The bone marrow is an organ. It just happens to be a more complicated organ. I'm sorry, I don't want to say anything bad about a lung or kidney transplant.
No,
those are all complicated things.
I debate it. I'll take a couple deep breaths. We'll see how that goes. Breath, get it.
But the bone marrow is a very complicated organ because it makes up all your blood elements. It makes up all your the whole immune system. So if you can imagine, with this simple transfusion of stem cells, the procedure itself is very simple, just a transfusion of the stem cells. But what happens later afterwards is what can be substantially affecting how the patient does. So after the transplant is done, even though David and his donor were well matched, David did develop graft versus host disease, which is one of the major complications after transplant. And you can imagine graft versus host disease is a condition where the donor cells are trying to reject the patient's body.
That's usually not the best thing.
Yeah, that's not the best thing, but it happens about 50% of the time after the transplant is done, in spite of taking medication to prevent it. Mm-hmm. So he had to go through that. He was on steroids, and he got better. But when we suppress the immune system, then that results in opportunistic infections from occurring. And he developed Cmv reactivation. The Cmv is a virus that 70% of us carry in our blood. And normally the virus stays dormant, but when the immune system goes down, the virus becomes active. And unfortunately, in David's situation, the virus landed up in his eye, and he developed Cmv retinitis. And I think at that time we had ID docs involved as well to help manage him, ophthalmology. And he actually got an insert in his eye that released ganciclovir, which is a drug that targets CMV. So he got over that, and he still has some residual visual defects from that retinitis. But then throughout, we checked bone marrow on David at 6 months, 1 year, and once a year now for the past several years. And we now check mainly in his blood. Everything looks great. He's 100% donor. So the way the transplant works, ultimately, is replacing the patient's bone marrow, which was diseased with the leukemia, with the donor stem cells and donor's bone marrow. So in effect, David has a much younger immune system in his body.
Can I go get that?
Yes.
No, that's probably a bad idea. Yeah, that's that hope, faith, and science, man.
Yes.
Sometimes the science is just
It's
so
amazing.
darn remarkable.
It is.
So Tricia, you help patients find a match with a donor.
Yeah.
Thank goodness for people like you. You guys, how long have you all worked together?
Oh,
10
more than
years.
10 years.
Yeah.
All right, I got 20 years here. The person I've been with, Joyce Funk, and I tell you that relationship is so important for patients because you all are the front line, their front face. You're the ones so often in contact. Tell us a little bit about this very complex process. Tell us how it looks, about how you get this marrow thing done.
Yeah, no, it is complicated and probably one of the coolest things that we get to do. So we talk with the patients when they're first diagnosed. We let them know that as transplant coordinators, we're there to help them find a donor should they need one. And then the process is somewhat simple in that they can do a buccal swab, which is swabbing their cheek, or we can get it from the blood as well. And we look for HLA, which is human leukocyte antigen, which is that genetic sort of piece that we're looking for. The lab gets it to us, and then we input it into the worldwide registry, which is the National Marrow Donor Program. As Dr. Abhyankar mentioned, there's 39 million volunteers on there now that help us look, and it's a big database that helps us sort, and then we look through. In addition to that, we type family members as well.
How often do you get somebody from, shall we say, across the pond to those matches kind of?
Probably half the time. I mean, it's we have a lot. I don't know why, but it seems like we do have a lot of European volunteers, more so on the registry than domestic volunteers.
So people just donate at a higher rate. So they join the registry.
That's right.
More than Americans do. So hey, America, get a message here.
That's right.
Get on the bone marrow registry. We'll come back to that point in just a minute.
Yes, that's right. So I think a lot of the time we are getting them from overseas.
How old can you be? I mean, what's the upper age cutoff to be a donor?
Yeah, so the National Marrow Donor Program is looking for volunteers that haven't turned 40 yet.
Okay,
So
I'm out of that one then.
18 to 39.
We are out.
I was on the registry when I was as a resident, though, just to be fair.
Yeah,
so.
unfortunately, you've come
I
off
didn't
at this
get
point.
called, but I'm off now, yeah.
But we take siblings older than that, or related donors. We can look at older than that, but to be on the registry, it's up to 40, so 18 to 39.
So I just missed it. Okay.
Just missed it.
Just missed it. All right. So what's involved for a donor and a patient when there is a match? What does that mean?
Yeah, there's a lot that's involved. A lot of it is blood work, especially for. So I'd say for the donor, there's a very intense history and physical that makes sure that they're healthy to donate and that donation is safe for them. That's extremely important that we take the safety of the donor into consideration. And then for the recipient, there's even more. So we need a healthy recipient, our patients, but we also need their disease under control, which is sometimes easier said than done. And then, of course, we need that donor. So there's a battery of testing that we do for our recipients: heart, lung, kidney, liver, and then, of course, making sure they have the social support to undergo a transplant as well. So there's a lot involved in the recipients because they have a bigger job ahead of them. For the donors, it's some blood work and then that history and physical.
Well, that's a very big deal. Okay, well, we're going to pause for just a minute. We'll come back to our conversation of the questions we have because we got to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention Control, who's got to go do some teaching this morning with Jessica Calendar-Rich, who's been on this program before
we love
too.
her.
So she's awesome.
Yeah.
And Hawk, how are the COVID numbers going?
Yeah, COVID numbers, I don't know, Steve, they've kind of been bouncing around low 30s, low to mid 20s. Today we're back at 22 active infections, 2 in the ICU. 0 on the ventilator, thankfully, and 26 in the recovery period. Again, still based on the CDC, still 39,000 cases on the 7 rolling day average every day. But trend continues to go down, and so hopefully we will continue to see that here. Of course, we are all concerned for moving forward into this colder weather with influenza rates increasing, as well as a possible recurrent surge of the circulation of SARS-CoV-2 as well.
Yeah, and that BA2.75 one looks like it could be coming into play a little bit more. Has in some countries. Could be a bigger number here. Let's talk a little bit about COVID items in the news. There's a little disheartening news out of the Kaiser Family Foundation showing a relatively few Americans, only about 7.6%, out of, or 17.6 million, sorry, out of 333 million have gotten the bivalent booster. You and I got it last week on this show when I looked super cool in a tank top.
Yeah.
Live long and prosper, people.
Of course. It was great. It was great.
That's what I thought, too.
It was a good start to the morning for everyone. But, you know, I think we have to get, so certainly continue to endorse those recommendations of the CDC, and everybody should be getting it. Those at highest risk, especially those above 60 or 65, those with comorbidities, they haven't had a recent vaccination or a recent infection, meaning within the last 3 months, it is vitally imperative to get that vaccine dose to help reduce your chance of hospitalization. So I think it is important, and I think people need to understand that moving forward, especially as we're getting in, as we said, into these colder months when we do expect increase in circulation and, you know, the new variant, but also any new variants that we haven't even identified yet as well. But luckily, what we have seen is with all the variants, the vaccines, if you are up to date, continue to provide you with very good protection against hospitalization and those severe outcomes.
You know, just as a quick thought, too, there was an article that came out in the Washington Post. It wasn't in the Washington Post. The Washington Post was reviewing it.
Yeah.
It was in one of the Nature journals, and talked about the impact of long COVID as well. So, and the concern is that such a large percentage of people are having it up to 2 years into the study now, have not fully recovered, and it's about between 13 and 40% of patients.
Yeah, and you know, we are optimistic and thinking a lot of those patients with those long COVID, those persistent symptoms would improve at 6 months, but we know there is that subpopulation that doesn't. It's very imperative, and we've talked about this, and we've seen this in our own health system, Steve, you know, led by Brandon Comfort and Leslie Spikes in internal medicine and pulmonary with these persistent symptoms. And we know it's a big issue. We know it is probably going to be another one of those comorbid conditions like heart disease, like diabetes. People are going to continue to have to seek medical care to help with the symptomatic treatment of this, and this is one more data point. Luckily, we know that there is funding going into asking these questions, investigating, and then also trying to come up with better treatments for these things. But certainly, moving forward, it will continue to be a large impact on people, even young people. You know, difficult to do daily things like go to work and regular activities of daily living. So it is very impactful for people if you get this, for sure.
And a couple of good thoughts. If you have a mild case, you're less likely to get it if you have more severe disease. And vaccinated patients who tend to have mild, we're going to come back to that in just a moment, also don't get as severe symptoms. So, I mean, again, confirming the importance of vaccination, and especially if you've had an infection, if there's time that's gone after that, you're so much more likely to get sick again if you get another COVID. And so vaccination really helps with that. Yeah. Also, another study that confirms what we've been saying about the VA hospital. The VA has this remarkable database, actually by far the strongest medical database in the United States, where we don't, you know, we're not all in the right database because we don't have great public health systems, but the VA does, and so one of the things they've been able to show is a very low incidence of COVID hospitalization after vaccination, which matches our own internal data here, Hawk.
Yeah, and we know they have, we were talking earlier about some of the Qatari data, and they're essentially more homogeneous population. We know and understand that some of the VA data, there are caveats because of a more homogeneous population, such as, you know, more men than women, age as well, but it's very good data to support that for sure. So I think we need to take those kernels of information, put that into the whole, and understand that is helpful to understand that for sure.
Yeah, good stuff. Well, listen, I know you've got to get going, so thanks for hanging out, Doc Hawk. Always a pleasure, and we'll be seeing you again pretty darn soon.
Yep.
Jess, I've got some more questions for our guests, but I'm going to see if you have questions first.
I'm going to see if we have some from our... Yeah, well, you know what? Go back to your questions, because I had a question about Alzheimer's disease, and now we don't have Dr. Burns, so we'll have to save that for our show. So I'm going to keep monitoring, but go forward with your conversation and then check back with me here in a few minutes.
You got all right. So Trish, if a donor lives in another state or country, do they have to come here to donate?
They don't. So for our related donors, most of them do come to KU to do the donation. The Be the Match National Marrow Donor Program does sometimes facilitate related collections closer to where that sister or brother or somebody lives, and then the cells can come to us. But if you live, if it's an unrelated sort of transplant, they do not come to Kansas City. If you live in a different country, you donate in your country, and the cells get moved to here with a live courier. Same thing throughout the country if you're donating.
So somebody takes those cells and flies them here. They personally fly them.
Yeah,
that's a big deal.
Yeah.
Carry-on luggage. Is it carry-on luggage?
It is carry-on. Yeah,
that's good.
yeah.
And any problem at the TSA checkpoints? I guess not.
You know, I haven't heard a whole lot about that. Yeah,
okay, good,
thankfully.
good. Yeah. So, is there any cost to a donor?
There should not be any medical cost to the donor. For our related donors, sometimes they do incur costs as far as travel and lodging, but anything medical is completely covered. For our unrelated donors, everything's covered except for probably time off of work if that's an issue. Yeah. But lodging, travel, all of the medical costs are covered by the National Marrow Donor Program.
All right, so you look through the thing, you find this match, what's your next step?
Well, it's a little bit like shopping on Amazon. I put them in my cart and I order them, and then
seriously?
it's kind of surreal when you do it the first time.
Yeah, that's okay.
So when you do that, then it goes through my case manager at the National Marrow Donor Program, then reaches out to the donor center. The donor center then reaches out to the donor, and then the donor gets back with them. They get blood drawn, we confirm everything up, and then kind of hit the ground running.
So when I go to the Amazon website, I look for Whole Foods, and now I have to look for whole blood.
It's a little bit to the right.
There you go, a little to the right. All right. Dr. Abhyankar, tell us a little bit about the options for a patient who doesn't have a match. What happens then? Because that's a little bumpier course.
It is, and this used to be a bigger problem like 10, 15 years ago. But since then, we have developed ways to do transplant using half-match donors. And most of us have half-match donors. These are usually for children, it could be the parent, a half-match. You know, each of one of us has inherited half our genes from mom, half our genes from dad. So we are half-matched to our parents, and most of the children also half-matched to the parents in reverse. So for patients who don't have a matched donor available, then we are looking at half-matched donors, either in the immediate family or also even the extended family. You know, you can go to cousins or your nephews and nieces. In the half-matched donor situation, we would prefer younger donors as compared to,
Yeah, I know you kicked me out.
Yeah, you kicked me. Yeah, so younger donors, and we also have to, if you have a choice of multiple donors, then we look at matching on the blood type as well. Because, interestingly, after the transplant, 3 to 6 months after transplant, the patient's blood type is going to change to that of the donor.
Which is pretty remarkable.
That is pretty remarkable, yeah.
So the blood type may be different, even though they're a big match.
Yeah, the blood type may be different, but yet they match at we now look at 12 different spots in the DNA for which we find a match.
And the reason you look at those 12 is that they predict a lot of trouble with rejection, and therefore if the bone marrows match better on those 12 slots, it doesn't say you're not going to have rejection. Because these, our guests earlier today had rejection, or the
graft
recipient
versus host,
did. Have a little graft versus host. And so when that happens, even if you match those 12 spots, it doesn't mean you're not going to have graft versus host.
No, it doesn't mean you're not going to have, but you have decreased chances.
Yeah.
So that is why, over the last many decades, transplant survival has improved because we have better matching techniques. We also can take half-match donors, we call it haploidentical or half-match donors to transplant. And we just did an analysis. One of our junior doctors who joined us did the analysis of our data at KU, looking at all the matched donors we've done transplant and the half-match donors, and our survival curves are exactly on top of each other.
Oh, that's really cool. Yeah,
that is really
great.
Yeah.
That is really cool. So, okay, lots of advances now in immunotherapy, and we and we could talk a little bit about what that means. But you're trying to manipulate the immune system to either kill cells or not kill cells, et cetera. What's going on here with AML? Any advances with that or other types of blood disorders?
So a lot of advances in the immune therapies have been made for lymphoid malignancies. So, for example, acute lymphoblastic leukemia, and where the first patient with the CAR-T, chimeric antigen receptor therapy, was a young, 14-year-old girl who got that therapy. And since then, now it's Fda approved for lymphoid malignancies. So patients who have B-cell lymphoma, or who have, common ones are diffuse large lymphoma or follicular lymphoma, patients, people who have acute lymphoblastic leukemia, we have CAR T cell therapy available. Acute myeloid leukemia, the kind that David had here, tends to be more complicated in that it is doesn't have a unique antigen on its surface. But people are trying to research a lot on this, and there are at KU we have clinical trials for using these immune therapies against acute myeloid leukemia as well. Dr. Lin and Dr. McGurk are both involved deeply in this and are principal investigators on many research studies. Yeah.
So when you do the CAR T therapy, and we've talked about it on this program before, what a remarkable achievement that is. Does it pretty well eradicate them, or are those patients still doing great who've had ALL or other blood disorders?
Yes, so for the patient I talked to you about, her name is Emily, and she has gone all over the world giving her experience, first in the world for CAR T.
That's remarkable.
So she is more than 10 years out from receiving the CAR T and continues to be remission. At some point we can say she's cured.
No, we hate to use that word.
Yeah.
Okay, here's my last important question for you, and then I got a question for Tricia, then we're going to go to Jess. Last question. Why is it as you get older you can't be a donor? What happens to us?
Yeah, that's a very
Because
interesting.
we may be about the same age, Sunil, I'm just saying.
Very true.
So defend our group here, buddy.
So several things happen actually. Our stem cell number decreases as we get older.
Oh, thanks
So
for
we
that.
get lots of stem cells from younger donors as compared to the older donors. Also, a donation for a little older person, they generally can have a little bit more side effects from the donation, especially if we're going to do a bone marrow harvest. And then most importantly, our immune system is now kind of used to our body, so to speak. It's less pliable, unlike a younger donor where the immune system is more pliable. So it is more likely to adjust to the new environment of the patient and cause less complications of graft versus host disease.
It sounds like you're saying to me we're running on empty. That's what it sounds like. I guess we can be careful with that. All right, Tricia, how common is it for donors and recipients like what we saw earlier in the program?
Oh gosh, what we saw today was extremely special.
Oh, that was special.
I have only, so I've done this for 10 years, and I've only seen personally maybe 10, probably less than that, donor meetups, and this is probably the only maybe the second that I've witnessed from KU that have met up like that. So it's extremely unique, very special. They become
really
like family. So it was really wonderful that we were able to that they invited us to experience that. I do think people probably meet up more off camera than I'm aware of, which is fine. This is a personal thing,
You mean they don't have to tell you everything about their lives?
Not usually.
Oh, darn. Okay.
Not after transplant, before transplant,
Just go check out TikTok. It'll be there. All right, good. All right, Jess, let's, last question. Guys, how do you become a donor if you're less than 40? I got that.
Yeah,
Thanks
it's
a
a
lot.
good question. So you can go to bethematch.org and you can register. They'll send, this might have a patient's name on it, but they'll send you a kit like this.
Okay.
It comes in the mail. Inside of it are some swabs, and there's a prepaid, pre-addressed mailer. You send it all back in. It's extremely simple. You stand in front of a mirror, swab your cheek.
There you go.
And that's it.
And it's called Be the what?
Be the Match.
BeTheMatch.org.
Yep.
America, go to BeTheMatch.org because the English and the Europeans are kicking our tail here. We got to let's get a little rally going on. Jess, what do you got?
Well, first of all, Tricia answered my favorite question. I was thinking about it ever since Dr. Abhyankar mentioned, how do you get an immune system onto a plane and across the ocean?
Fly it across. Yeah. And the answer was whole blood on Amazon. I got it.
Yeah, so you go to Amazon to order it, and then it goes in your carry-on. I love that.
Yeah, you have to make sure it doesn't get radiated to the TSA. No radiation.
So let's see, that means it really can't go through the camera thing that they're the scanner then.
It cannot, yeah.
Guys, don't scan the blood. Got it.
Yeah, fun fact. That was a very fun fact. Question from Tammy wants to know if a bone marrow recipient has to stay in isolation after the transplant, and if so, for how long?
So it depends a lot on what kind of transplant we've done, but typically about, the duration of the actual transplant is about a month stay in the hospital, 3 to 4 weeks in the hospital, and they're quite in isolation then. But subsequently after the person discharged from the hospital, then about the first 100 days, they have to be very cautious about being exposed to infectious agents, so avoid crowds, avoid situations where they can catch infections for the first 100 days.
Okay, so try to be
Joellen wants
safe.
to know, last question is, Joellen wants to know, can great nieces and great nephews be potential donors, or is it the farther away you get from your siblings and your parents and your own children, the less likely they are to be a match?
Yeah, that's absolutely correct. The further we go away from the immediate family, the less and less chance of being a match. But saying that, we have had grandchildren donate to their grandparents. So it's always worth checking it out, especially if you don't have a good donor options in an immediate family.
And
All right.
Dr. Stites, I have a question though. Can you have a donor match that, even though if it's not a great match, is it still good enough, or does it have to be a certain level of a match, or is it just, if it's not good, it's not good, or do you find the best match you can, or do you just have to wait for the best possible match? Does that make sense?
Yeah, I understand the question. So even the half match situation, where let's say a child is donated to a parent or vice versa, we want a half match. So when we look at these, 10 of 8 different spots in the DNA, we want them to match at 50% of those spots, and that's why we call it a haplo. We generally will not want somebody who is less than half a match. And then, of course, to the donor registry, where we are unrelated donors, not part of the family, but out of 39 million donors out there, we would prefer to find a perfect match, matching across all 10 to 12 genes in the HLE.
Dr. Abhyankar, one last question is there any specific, and you may have mentioned it earlier, but is there any specific race or background that needs the most donors on the registry?
Very good, very important question. And so if you see, let's say we have a donor who's Indian like me, and we want to find a match from the donor registry, the chance of finding a match is about 40%. Whereas if you are 40 approximately, and on the other hand, if your ancestry is mostly Caucasian, Western European, you have almost a 79-80% chance of finding a match. And African American descent, about 30% chance of finding a match. So what that basically means is that you have to screen a lot more donors to be able to find a match for somebody who has African American ancestry, for instance.
Dr. Stites, I'll let you get to some final thoughts.
Yeah, you bet. I have one more question for our team, though. You hear about people having children so they can find a match. Have you guys ever had an encounter with that?
I think that's probably more than pediatrics, maybe?
Yes, it's more in pediatrics, and a movie has been made about that. A famous book has been written about that, and gets into a lot of ethical issues then.
There's a lot of ethical stuff around that. But well, guys, this has been a great program today, and I think we probably all have some final thoughts, but I want to thank you guys both for being here. It's been awesome. Dr. Abhyankar, I want to start with you for final thoughts today.
This is, we started off a very nice story of David, and our only hope we keep replicating such stories on all our patients. Unfortunately, even with all the advances that we've made, often it's long-term success, about 50-60%. So we still have a lot of work to do.
Yeah. Well, congratulations on the work that you have done. Dr. Abhyankar is an outstanding physician. I've had the great honor to work with him multiple times. He does a great job. He and the whole BMT team, Dr. McGurk and everyone, that team. Oh my gosh, what an amazing, amazing team of folks. And Tricia, you're part of that team. Yeah. That means you're amazing.
Oh, thank you.
So bethematch.org. Talk to us about your final thoughts.
Yes, and I would echo that. We have really the most outstanding team that I've had the chance to work with, so I feel extremely privileged. Something that I just did want to add on to what Dr. Abhyankar was addressing as far as disparities that we see on the registry are those of mixed race. So while we'll see, 30% of African Americans I can find a donor for, and 40% of like an Indian American, perhaps if they were a mixed race, it's much, much less than that. So if you know some folks that are of mixed ancestry, mixed race, that's really where the National Marrow Donor Program, the Be the Match, is looking to get those people on the registry so we have a better representation for our patients. That's a really big deal. Everybody knows I love Star Trek, but the live long and prosper, right? How do we do that? One of the remarkable points of this show is to show that this program has been to talk about the human element, and today I think we nailed it with that opening story, and the story too of how once again it's not the color of your skin, it's not even the
shape of your body. It's really about your ability to be a donor. And the more donors we have, the more we're all helped by that. And the other, just to say, remarkable part of this is the importance of that physician and that team relationship with patients that helps to sustain them. We got all this international travel from countries all over the world. Government's not involved, we can get it done safely. And once again, showing the sanctity and the importance of that relationship between the patient, their team, and the folks all around us. And the more that we're in this together, the better off we can be. Jess, back to you.
Thank you so much, Dr. Stites, your guest, and thank all of you for joining us today. We'll be back tomorrow at 8 o'clock with another morning medical update. We will see you then. Have a fantastic day. Coming up tomorrow on the Morning Medical Update, a love of the stage led one woman to a career in nursing. Now, nurse Tiffany Schweigart is back in the spotlight, combining her two loves of art and medicine. I'm Jessica Lovell. Join us Thursday at 8 when Tiffany brings to life the play that charted her career path in mental health. I'm Alexis Del Cid on the next All Things Heart.
Like, it takes all my problems away.
17 years old, addicted to drugs, and pregnant. Each pill could be deadly. We explore the heart connection to fentanyl and the new dangers to our children, Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.